Hello, everyone. So I'm going to talk a little bit about what genetic testing can help us with, specifically for adults with congenital heart disease. What we're going to go over is just some general genetic concepts, what genetic testing is available currently, genetic causes or etiology of congenital heart disease, why we would do testing or genetic testing in adults, and then recurrence risk or risk for having a child with congenital heart disease. I have a couple disclaimers. One is that genetics is really hard to understand. Genetics is something that takes a lot of education to understand, and education and intelligence are very different. So do not, there are no stupid questions. Do not hesitate to ask questions that you have, because it is really hard to understand, and the purpose of this is to help educate people. Genetics can be emotional. A lot of people feel guilt and other feelings tied to genetics. We have no control over our genetics. It's who we are from when the sperm meets the egg. We have no control what our children inherit or what we got from our parents. But still, a lot of people feel some guilt when they're talking about genetics, even though it's not anyone's fault. Genetics is always changing. Whenever we find something new, 10 minutes later, it feels like it's already out of date. So we're discovering new gene associations, new technologies every month, every week, every day, it seems like. And then finally, it can be hard to find a medical geneticist. I know for this population who you guys have trouble finding a cardiologist, it's also hard to find a medical geneticist. So sometimes it can be difficult to get an appointment to talk about these things that we're discussing. So first, going into some general genetic concepts, I like to think of your genome as a library, and sort of within each cell, there's everything that makes up you and all the information that makes up how you formed. I like to think of your chromosomes as bookcases. We have 23 pairs of chromosomes, one that comes from mom and one that comes from dad. And then on those bookcases are all the books or all the genes. They all have various information, and we have over 20,000 genes, but you can read through them letter by letter like a book. You may also hear of something called an exon versus an intron. You typically hear that is exome sequencing versus genome sequencing. So the exon is the coding part of the gene. It's the part that actually makes a protein. So I think of it like chapters of the book. So when you're looking at a book, the title page, the cover, all those other things are important, but what you're really looking for is the content. And so the exons are the content of the genes. Everything around them also are important and influence it, but we're really focused on the coding region. And variants, so changes within those books or within those genes, are like typos, and there's nothing inherently good or bad about a variant. Variant can cause disease. A variant can be benign. We all have millions of benign variants in our genome. I think of it as if you've ever seen color spelled with a U. So C-O-L-O-U-R, a computer might mark this wrong, or depending on where you are, might mark C-O-L-O-R wrong. But when your brain reads it, it knows exactly what it says. So variants are the same way. They can disrupt the spelling, and a computer can mark them as wrong, but they could actually keep the message intact. And so I also think that you can have pretty disruptive variants. So my high school English teacher would be very upset if he saw me spelled right like that. But we all know what the sentence says still. We also like to simplify genetics to try to help understand things. We say that one gene causes one feature. This gene causes your hair color. This gene causes your eye color. This gene caused your heart disease, that sort of thing. So we say if a gene's damaged, that results in disease. But in reality, it's much more complex. These genes are working in complex networks with each other and interacting and affecting each other. So I think of it like a game of telephone, where a gene can start with one message and other genes can come in and modify that message. They could correct it and compensate for it, or they could make it more disrupted. And then the story you end up at the end, or the how your heart formed at the end, could be different in each individual family member, depending on the exact combination of variants they have. So this leads us to penetrance and expressivity. So if you look at the dots on here, we have a purple dot and a white dot that have made a bunch of baby dots. And so if you look at the left panel, that's what we call variable penetrance. So all of those dots are genetically purple, but some look white and some look purple. So you can have a genetic disease, and you may have features of it, you may not. So this can be present, this is specifically common in things like bicuspid aortic valve. You also can have variable expressivity. So everyone genetically is purple. However, there are different shades of purple, so it's a little different. And then where we live most frequently in genetics is variable penetrance and variable expressivity. So once again, an example would be bicuspid aortic valve. A family with a gene that is at risk for that could have a child with everything from hypoplastic left heart syndrome up to a bicuspid aortic valve that is fine when they're 90. And so the reason we have these things, why the exact same change can be different in different family members, is because it's not one gene working in isolation. It's our unique combination of genes and variants. So moving into the genetic testing. So genetic testing that's currently available. So the test that's been around for the longest is the karyotype. You may hear it called a G-banded karyotype. That just means the type of stain the chromosomes have gone under. It is a very simple test that checks number and general structure of the chromosomes. It can only detect very large anomalies, and that would be things like trisomy 21 or Down syndrome, or something like 45X or Turner syndrome. So for the most part, for most of our patients with congenital heart disease, this test isn't necessarily going to be helpful. However, particularly for people born, honestly, even in the 2000s, probably before 2010 for sure, this is possibly the only test they would have had done. The next most common test you'll see is FISH, or fluorescence in situ hybridization. What this is so that picture of black is a single cell, and all of those color dots, the color dots are attached to a sequence of DNA that then binds to where that is in your chromosomes. So this is something that most commonly in our population we're talking about for FISH for 22q deletion syndrome, or FISH for DeGeorge, sometimes it's called. And so what that is it's a fluorescent light like this that you can see under a microscope that's set to bind specifically to that part of the DNA. And you look for making sure that there's two copies, so two sets of that chromosome in that region. So once again, going up to mid-2000s probably, and starting in the very late 90s, this might have been a test that some of you underwent. If you were born in that era, a lot of times we haven't caught up to testing all of our adults with necessarily any genetic testing. Now moving on to the test that we use most frequently. So that's called a chromosomal microarray, or a microarray. This looks at DNA ratios. So something that you may have noticed under my karyotype slide is I put resolution to about 10 megabases. And here under this picture of the microarray, I have a resolution to 0.2 megabases. And I'll make sure to talk about what resolution means, but even just looking at those numbers, you can tell this test looks at the genes much more carefully. So all this does is look at DNA ratios. So it can detect things like 22q deletion syndrome and other causes of congenital heart disease like Williams syndrome. It can also detect what we call non-syndromic forms of congenital heart disease, like, for example, AP23, often those patients have congenital heart disease, but not necessarily other features. And it looks over your entire library for missing or extra genes. So this is a very powerful test. In 2010, this test was recommended to be first-tier evaluation for babies with major congenital anomalies. So patients that were probably born starting more 2015-ish because it takes us a while to pick up these recommendations, are likely undergoing routine microarray analysis. But if you were born before then and you didn't go back and get genetic testing, it's extremely unlikely you've had this test done because it just didn't exist. So in our patients who have congenital heart disease who have surgery in the first year of life, we find an answer on microarray testing about a quarter of the time. So there's a reasonable likelihood to finding an answer with this test, which is one of the reasons why we do it. And knowing that can help us take better care of our patients. What we also know about our adult congenital heart disease population is you guys have survived a completely different world than what our infants are in today. And even by decade, that's changed. So what exactly the rates that we see in our infants today are, and as they apply to you guys, we're not completely sure that that is going to translate over completely. Because when you have a chromosomal abnormality, not all, but a lot of patients are at increased risk for other health issues, which is why we test for it. So there probably is a reasonable likelihood that the patients that had these risks didn't survive earlier care plans. So it's likely, but we don't know yet, that adults with congenital heart disease who are 30 and above, 40 and above, are less likely to have something that would show up on chromosomal microarray than infants who are born today. Now, so the array tells, this talks about resolution too. So I mentioned resolution. What does resolution mean? It just means how many base pairs we're really looking at. So 10 megabases, for reference, the 21st chromosome, or the chromosome that's extra in Down syndrome, is 46 megabases. So you're looking at something that's like 20% the chunk of a whole chromosome when you're looking at karyotype, versus 0.2 megabases with the array. That's still 200,000 base pairs, but that's much, much smaller. And now we're going to talk about single base pair testing or single gene testing. So once again, the array will tell you if there's missing or extra, but it doesn't tell you anything about what the genes say. And we know that genes can have typos. So when you get genetic sequencing or single gene genetic testing, it can mean a lot of things depending on the specific test you had done. So it could be for one single disease, it could be a panel looking for a lot of related diseases, or it could be something like an exome where you're looking at all the genes. So when you have a single gene test or genetic sequencing, sort of the devil's in the details, and we're discovering new genes and new disease associations every day. So even if you had testing 3 years ago, the test we would do now may be different. And so moving on to exome sequencing, this is where we're trying to go with the first year for a lot of our patients. Unfortunately, insurance companies haven't caught up to us. So once again, talking about the chapters, the meat of the genome, But the exome is still only 1% of your library. Genes only make up 1% of all of your DNA. And we know that the other parts of the DNA are important, but we don't necessarily understand how they cause disease yet. So when we're focusing on the exome, even then we say we're sequencing all the genes, but we're still only looking at 1% of the library. I think that's good to know just because it shows how much we still have to learn about genetics. Okay, and I think we have a question.
Yep, so one of the questions that came in is with all of these different tests, should we know what test to ask with our cardiologist, or will they know and recommend what test we should be taking since these are all so different and get at different diagnoses?
That is a great question. So a little of both. It's always very reasonable to go to your physician with, should I have a microarray, or should I have this panel, or should I have an exome? But it's also fair to say to your cardiologist or your physician, should I have genetic testing? And they ideally should know, yes, this is where we want to send you, but they might say, you know, your case is kind of complex. Why don't we have you meet with a geneticist? So it's possible that they may say, yeah, let's do that testing. Let's get a microarray done. Let's do a panel for cardiomyopathy. Let's do a panel for aortopathy, or let's do a congenital heart disease panel. It's also possible that they'll say, you know, there are a lot of options. Why don't we have you talk to a geneticist who will choose which one is the best fit for you? So a little bit of both. It's always good to be an informed consumer, but you definitely don't have to be.
Okay, thank you.
No problem. So once again, going to the exome, so it looks at all 20,000 genes. It can, because it looks at all of them, it can find things that might be unanticipated. So it can find things like risk for cancer. It can find things like risk for heart failure. And it can find things that may have implications for the family because, yeah, maybe you knew that your aunt had breast cancer, but now you find that there's BRCA1 or BRCA2 in your family, and it sort of can open Pandora's box of now we got to talk to Aunt Sally and Cousin Gina and everybody and get everybody tested. So overall, that's good because it means we can take better care of people and keep your family safer, but it can be a little dramatic. Even with exome sequencing, we still miss diagnoses. So there can be specific types of genetic diseases that just aren't looked at with this. For example, there's something called Fragile X, which is a common cause of developmental delay in children, which is caused by the same genetic sequence going over and over and over and over again. For exome sequencing, because it takes small chunks of DNA and maps them into where they think it should be, repeats of the same thing over and over again get kicked out because the computer thinks it's an error. So we wouldn't be able to detect something like that on exome. Once again, that's not something you need to know, that's something your doctor needs to know, but it's just good to keep in mind that there is no one single test that tests for everything in genetics currently. So the other thing I want to talk about is that less than a third of the genes, of the 20,000 genes, are actually associated with human disease. So even when we're looking at the exome, we're looking at less than a third of less than 1% of your library. That being said, when we do this test on people that we know have genetic disease, we're still finding an answer a third of the time. So while that's a frustrating number for us because we want it to be higher, it's actually sort of an amazingly high number when you think of how little of our genetic information you're actually looking at. Now, moving on from testing to what causes congenital heart disease, this is something that we could talk about for hours and hours. Sort of broadly, you can talk about chromosomal abnormalities, the most common of which is something that most people are familiar with, Down syndrome or trisomy 21, so having a complete extra copy of one of the chromosomes. And so that is a really common cause of congenital heart disease. Typically, our adult population, if there is a major chromosomal abnormality like that, it's already been diagnosed. Then copy number variants, and you'll notice this goes kind of from size down. So that's missing or extra genes. Chromosomal abnormalities is typically missing or extra chromosomes, then going to missing or extra genes. And so copy number variants, once again, in a quarter of our babies that have surgery before a year of age, we find copy number variants is the answer. So that is a very important cause for congenital heart disease because it can help us take better care of these patients if you are one of those quarter of patients. For example, some of the things that we look for are like this predisposes to hearing loss. So we make sure we check that baby's hearing more frequently. We also know that just having congenital heart disease and going through surgery and all of those things seems to increase your risk for hearing loss. So potentially having a double hit makes us even more concerned. The other thing we can talk about is single gene disruption. This can have a wide variety of presentations, and I'm guessing that if genetic testing is going to give us an answer for the adults, single gene testing is more likely to give us an answer than copy number variants. Once again, just because some of the patients with copy number variants have some significant other medical morbidities that maybe would have made it harder for them to survive. Where we are with a lot of our congenital heart disease patients is the multifactorial, multigenic sort of category, where you don't have congenital heart disease for just one reason. There are multiple different reasons that can all factor in together, and it's that game of telephone and that spider web of interacting features. So it's because I inherited these 17 specific variants in combination that I had congenital heart disease. Leading into that is there can be environmental contributions as well. For example, heat is considered a teratogen, and heat exposure early in pregnancy can contribute to congenital heart disease, specifically fevers. So it's possible that you had 16 or 17 variants plus mom had a fever plus other things. So once again, these things aren't anyone's fault, it's just how it happens. But there can be other things that influence how the genes work and how the body forms. And all of that can be really hard to measure because the other thing is lots of people have fevers during pregnancy and don't get congenital heart disease. So just because we see a pattern, we don't know how it works, and still there are genetic contributions. So when I think about patients with congenital heart disease, I think of it as genetic in that it's intrinsic. It's how your heart was going to form when the sperm met the egg. It's possibly influenced by other things that have happened, but largely there's something intrinsic. That doesn't mean that it's inherited or that it's going to happen again. It just means that it's nobody's fault. It's part of who you are, and we like who you are, so we will continue to take care of you. And so why does this matter? So you might be thinking, hey, I'm 40, I don't really care what my genetics are. Why does this matter? She keeps talking about babies. Well, there are a lot of potential reasons that that matters. One is potential screening for complications. For example, there is a gene called JAG1 that can cause anything from isolated tetralogy of Fallot up to something called Alagille syndrome, which is when a baby has liver disease and heart disease. So patients with JAG1 variants that cause disease or pathogenic variants in JAG1 can be at increased risk for stroke later in life. So if we know that you have congenital heart disease due to a pathogenic variant in JAG1, we say, hey, we need to watch for this. We need to talk about what the symptoms are for this. We need to talk about what the plan is if you start to experience these symptoms. The other thing is patients with variants might not have congenital heart disease. Maybe they just have a risk for stroke. So it's possible that this could be in your siblings or your parents, but we don't know about it because they don't have heart disease. So it's sort of going back to those different shades of purple. It all can be related, but how patients look and how each family member looks can be very different. So it still can help us take care of you, even if you're an adult. So the place where we're going more and more is for potential medication intervention. So we're trying to use genetics and genetic diagnoses to take better care of our patients. For example, there is a really specific cause of congenital heart disease and heart failure. Often patients also have short stature. They're called RASopathies, an example of which could be Noonan syndrome. So Noonan syndrome is actually pretty common. It's estimated at about maybe 1 in 3,000. So once again, going back to trisomy 21 or Down syndrome, that's about 1 in 1,000. So if you think I have met more than 3 people with trisomy 21, you've met someone with Noonan syndrome too, whether you knew it or not. So it's a common diagnosis, and patients may just have short stature, they may just have pulmonary stenosis, but later in life, they're at risk for cardiomyopathy or heart failure. And just last month, there was a paper published for a specific drug being used to treat that kind of heart failure. It's something called a MEK inhibitor, but that sort of detail doesn't particularly matter. What matters is that if you have Noonan syndrome, this medication will help your heart. If you have heart failure for any other reason, it's not going to. So knowing that information can help us give really specific medications to treat your exact cause of disease. As I sort of mentioned a little earlier, screening partially affected family members. So once again, if you have heart disease, but perhaps your sister only has risk for stroke, those sorts of things, that can really help us take better care of your family members. So it's important to know. That being said, just as we talked about, still when we test most of our patients, we don't come up with answers. But having testing where we've at least ruled out most of the things we currently know how to identify, which we call non-diagnostic testing, can be helpful too and give you peace of mind. And then the next thing, which we'll talk about more specifically, is recurrence risk and family planning. Well, before we get to that, though, it looks like we have a question.
Yep, we have a question from the audience.
Mm-hmm.
So if a patient with a single gene disruption for congenital heart disease saw a geneticist, that geneticist might be able to tell that patient what else to be aware of outside of heart issues. Is that correct?
Absolutely. So if we have a diagnosed single gene, we can tell you more about that diagnosis and what to expect. Some places where we've discovered that the gene causes disease, but we're not necessarily sure what it means long term. So sometimes we have less information about a gene, sometimes we have more. It really depends on the exact diagnosis. A lot of it also leads into clinical experience. For example, there's a cause of bicuspid aortic valve called Notch1, and it can also cause dilatation of the aorta. So knowing that we need to watch for that in patients with that and possibly look for other things. There's also a gene called MYH7, which causes cardiomyopathy, but also can cause a wide range of cardiac defects. So if we found an MYH7 variant in a patient with hypoplastic left heart syndrome, for example, and then we found one of the parents or somebody else had an MYH7 variant, we would actually screen them for cardiomyopathy, even if their heart formed completely fine. So we can give you as much information, and in genetics, we're also very frank about where we're still learning and what we still have more information to learn about. So now going on to recurrence risk. Recurrence risk varies significantly. It can vary from like 1% up to 50%. So depending on what exactly is going on in your family and what specific type of lesion you have, we need all of those factors to sort of bring together and make a really specific recurrence risk for you. So that being said, we also have a lot of data on patients with congenital heart disease having children. So we can say that overall, as a male with congenital heart disease, you typically have about a 3% risk for a child with congenital heart disease. And for unfair reasons, if you're female, you have a 6% risk. So we're not exactly sure why females have a higher risk than males. I have my own personal theories, but they have not been proven. So that's the average across everybody with congenital heart disease who has a baby. Once again, we're seeing a lot of change in that population too. We're having patients with much more severe congenital heart disease and single ventricle congenital heart disease have babies. So that number may change. And that number has changed in some of our early information. For example, our patients with hypoplastic left heart syndrome. So by hypoplastic left heart syndrome, I mean very specifically aortic atresia or stenosis, mitral atresia or stenosis. There are other forms of hypoplastic left heart syndrome, like an unbalanced AV canal or a double outlet right ventricle, which are very different. But if you have that form of hypoplastic left heart syndrome, your chance for having a child with congenital heart disease is 22%. So that's a huge difference from 3 or 6%. So really getting into those weeds and getting into that detail can mean a lot. Compared to if you have transposition of the great arteries, you have a 1.5% chance of having a child with congenital heart disease. So once again, that's a huge difference in the other direction. So, and the baseline population risk is 1%. Sometimes people with things like Epstein anomaly will go back to having a 1% and be back at population risk. So the devil is always in the details with genetics. So we can give you the general number, but also if we have your family history and the exact lesion you have, we can often personalize things much more specifically. As I said, it can range between 1% up to 50% depending on the exact situation. Sometimes even when we don't have an exact genetic cause, just based on family history, we can say you have a risk of up to 50% because this is strong in your family. For all patients with congenital heart disease, even if you just have a minimally increased risk, I do recommend a fetal echocardiogram with a pediatric cardiologist. So there are lots of different types of providers and physicians who do fetal echoes. The reason that I personally prefer to do fetal echoes with a pediatric cardiologist is all they look at all day is hearts. And all they do is take care of children with congenital heart disease. So our colleagues in maternal fetal medicine and those sorts of things are very skilled, but they don't look at hearts all day. So when I'm particularly thinking about really subtle things like anomalous pulmonary venous return or coarctation of the aorta, which can be really hard for the most experienced people to see, I want my fetal echo with a pediatric cardiologist. And that's a personal bias, but one I would recommend you have too. The other thing, going back to just general environmental perspectives, so ideally, if you're planning on getting pregnant, so the recommendation is for all women of childbearing age to take a prenatal vitamin every day. So even if you have birth control or an IUD or something, the general recommendations are for you to take a prenatal vitamin. However, if you have congenital heart disease, I would take a prenatal vitamin and extra folic acid if you're planning on getting pregnant. Ideally, this would start a few months before pregnancy, but we all know that's not really how the world works. So once you find out you're pregnant, it could still be helpful to take a little extra folic acid. The reason that I recommend that is that there have been some studies linking folic acid to the development of congenital heart disease. It's most commonly associated with spina bifida and neural tube defects. So it's an incredibly low-risk thing that we could do that might provide extra protection. It's also important to remember in this day and age of organic things and gluten-free things that we add folic acid, we enrich flour with folic acid. So if you have a completely organic diet, you are not getting extra folic acid that is through that enrichment. Also, if you have a gluten-free diet, you are not getting that extra folic acid. And we know that enriching flour and bread with folic acid has really decreased the rate of neural tube defects. So we know that that has had a positive effect, but with more commonly people are doing organic and gluten-free diets, it's possible that those things could creep back in, although we have no data to suggest either way at this point. So conclusions. Genetics is complex and changing every day. If there's one thing that I think that you can take from this is that if anyone says they know everything about genetics, they know nothing about genetics. You cannot trust them because nobody knows everything about genetics. It is way too complex and it changes every day, and we have so much to learn. Genetics is becoming more important to adults with congenital heart disease and all patients with congenital heart disease because we're able to make better treatment and better screening plans. And even without a genetic answer, we can give you an idea of your reproductive risk just based on your family history and your specific cardiac lesion. So with those two details, we can give you a pretty specific answer even if we don't have a genetic cause for your congenital heart disease. And so I want to thank you for paying attention. It looks like we are going to have plenty of time for questions.
Yep, and I just encourage everybody who's tuning in, if you do have questions you haven't submitted yet, feel free to send them through the chat function to the host. It's listed as From a Heart Institute. We do have a couple to start, one being, I'm interested in having a whole exome sequencing done. Will my insurance cover this?
So that's a great question, and insurance coverage is something we deal with a lot. So if we ask, should your insurance cover it, the answer is yes. Will they? It depends on the exact insurance program and the plan. So we do, whenever we're doing exome sequencing, we do prior authorization, which means we send a letter to the insurance company discussing why we should do this testing and what we're looking for. So some insurance companies will just say, still, we're not paying for it. We have a genetic exclusion. But some, with our letters, will say, hey, you're making a lot of sense, let's do this. So even just a couple years ago, in 2015, we had a lot of trouble getting it covered, but now in 2019, we still have some trouble, I'm not going to lie, but it's way, way less. We are getting things covered way more often. Some situations like Medicaid, we still have a lot of trouble with, and some specific insurance plans, but there are some plans where we see it and we're like, oh yeah, we're going to be able to get that covered, which was not the case even just a few years ago. The other thing is the cost of genetic testing is going down. It's something that you can always be aware of and ask us about because typically we're aware of it too. And genetic testing that is very similar may have very different costs at different labs. So it's also reasonable to be an informed consumer from that standpoint. So I would say the cheapest exome that I've seen around is about $2,400, which is still over $2,000. But once again, even just in 2015, we were talking more like $5,000 to $10,000. So the cost keeps going down, and hopefully it will continue to go down further. I still think insurance should be paying for that for us, but it's reasonable to ask of, hey, my insurance said they'd pay 80% of it, but I might still have 20% of this. Where are you sending this, and what does this cost? And typically, we're able to give you pretty specific information for that.
Okay. Another question that came in is, if I want to see a geneticist, how do I go about arranging this?
So if you are here, so typically geneticists are uncommon. There's maybe about 9 of us in the state of Wisconsin right now. So typically we're clustered at academic centers. So for example, if you wanted to come see us at Children's, and we do see adults and children's just like the ACHD program, the number for scheduling with us is 414-266-3347. That's 266-3347. And if you're someplace else, typically most places that are going to have an adult congenital heart disease program are also going to have a geneticist, just because they're more around academic centers. So your ACHD doctor probably has a geneticist that they can refer you to. And if not, they should be able to tell you where the closest one is. For example, there's ones in Chicago, Madison, Marshfield, I think LaGrange. So there are a couple different places around the state that you could access, and your cardiologist should be able to help you identify and find one. But once again, if you want to see us down here in Milwaukee at Children's, the number's 414-266-3347.
Okay, thank you. Another question, so how are these genetic tests done? Is it a blood test, a saliva test, and how long would I have to wait for the results?
That is a great question. So depending on the test, we can use various different samples. So typically for a more in-depth test, like an exome or a genome or something like that, we do need blood because we need a lot of very pure DNA. If we have a variant that we're looking for and we're just looking for one variant, we could do a cheek swab, we can do a spit kit. So spit kits sound really easy, but it's actually a lot of spit. It's like 3 mLs of spit in a huge tube.
Oh boy.
So it's actually pretty hard to get from kids, and it's a little bit harder to do than it sounds like it should be. The buccal swabs are very easy, though. We also can do genetic testing on tissue if it's frozen or live. So if you had surgery done on your heart and you had a transplant and they froze part of it, we could possibly do sequencing on that. So there's a lot of different ways we can do genetic testing. Most commonly, it's a blood sample.
Okay, thank you. Another question, I'm male and I have a congenital heart defect and thus won't be getting pregnant, but my wife who does not have CHD, should she be receiving genetic testing as well?
So the American College of OBGYN, so this is more general genetics and not really anything to do with cardiology. It recommends that all women get screened for a couple of things. One is cystic fibrosis, because especially in the Caucasian population, about 1 in 25 people carry that disease. The other is spinal muscular atrophy, which is a little less common, but still now has a treatment for it. So we're recommending that women get screened ideally before they're pregnant, if not during the first pregnancy. And then sickle cell anemia, which is something that's actually on the newborn screen now. So cystic fibrosis is on the newborn screen too, and we're working towards getting spinal muscular atrophy. But if we know a baby is at risk for a genetic condition or we do prenatal genetic testing, we can take better care of that baby. Genetic testing kind of has a bad rap during pregnancy of just being used to make decisions regarding termination, but that's really not the case. I'm a pediatrician, so I use genetic testing to take care of babies. And our population really doesn't use genetic testing in the prenatal period as much as would be helpful. Of our prenatally diagnosed congenital heart disease patients, only 15% undergo prenatal genetic testing. And often the reason that I'm given is, well, it wouldn't change anything. And it's like, well, I know it's not about termination. It would change things for me and how I take care of your child. But still, a lot of people have some biases against prenatal genetic testing. So getting carrier screening, and you can get broad carrier screening, is definitely recommended and very reasonable. And you can meet with a prenatal genetic counselor who can help you guys do that. But for the most part, it's actually for stuff that's not related to congenital heart disease. And that's most common the reason that we recommend it. So, so your wife might need genetic testing, but not really for the heart stuff. It would be for other stuff. And I would still recommend that she take a prenatal vitamin and extra folic acid.
Sure. Thank you. Another question that came in, since genetics and clinical studies are always changing, how often would you recommend seeing a geneticist?
That's a great question, and there's no one right answer to it. I tend to go based on how often, how severe, I guess, your medical concerns are related specifically to the genetic aspect. So the most frequently we reanalyze data is yearly. But for our patients who are who have maybe more isolated transposition and not too many problems, we might say, well, come in 5 to 10 years, because it's going to take us a while to learn more about that. For our patients that are more middle of the ground, where I have a complex lesion like tetralogy of Fallot that genetically we're learning more about tetralogy of Fallot every day, and there's a lot of potential conditions, very rare, but still potential things that we could change our care for. I would say more in the 3 to 5 year range, probably more around 3. But the answer is there is no right answer. The most frequent is yearly, and up to, maybe every decade or so. But ideally, it's probably more in a 3 to 5 year range. And some of that you can still do with your cardiologist too. You can say, hey, can you reach out to genetics and see if they think I need updated testing or an updated conversation? And that's reasonable too. We get asked that all the time.
And because with that 3 to 5 year time frame, is it require a new genetic test every time, or sometimes can you use the former test and just reevaluating it with the knowledge that you've had since then?
That is a great question. So so if you've had exome sequencing, for example, we don't redo the exome sequencing. We reanalyze the data because your genes don't change. Our knowledge about them does. Occasionally, we will start updating testing for advances in technology. So typically, I'm predicting that if we have an exome on a patient, the next time we would probably update the technology from a sequencing standpoint would be to Genome. So taking that 1% and going to the whole apple and sequencing the whole library. But right now, the vast majority of that information, we don't even know how to interpret. So getting a whole lot more information, which costs a lot more, that we don't really know what to do with, isn't particularly reasonable right now. As genome sequencing, gets cheaper, it will become more reasonable, but that would probably be the next step if you're at an exome step right now. If you have a microarray, then yeah, we would say, okay, let's do sequencing. But a lot of times, it's reinterpretation of existing data if you've already had testing.
And you've been talking about this a little bit, Elle, but I just want to ask it very specifically. Once you have that genetic test done, is the patient still seen by that geneticist, or is it mostly managed by their physician, their cardiologist? How does that relationship work once the test is complete?
All of the above. So when we have patients with a diagnosis, we often check in yearly to every 2 years, depending on exactly what the condition is. A lot of times we're here to talk about diagnosis and then educate your other providers about the rare disease so that they can take care of it. For example, if we're worried for an arrhythmia risk, we would talk to your cardiologist about it and they would take care of you. If we're worried about a stroke risk, we might check in with your neurologist and talk to them for you. So it sort of depends on exactly what the diagnosis is. There are some patients that have really specific genetic diagnoses where we follow even up to monthly, but typically those are not things that cause congenital heart disease.
Okay. And I think that's all the questions we have time for today. I do want to thank everybody for participating today and for your questions.